very kind introduction. It certainly is a pleasure to be here on behalf of IPSS. It's also a pleasure to see the list of participants and see a lot of good friends in that list. So hello to you all. I know you're scattered around the world, and it's noon for me, so it's an easy time, but I know for other folks it may not be so easy, so we definitely appreciate your participation. The title of my talk is Using Simulation-Based Methodologies to Answer Clinically Important Questions, and I think this is something that has to drive us as pediatricians. Um, Simulation for simulation's sake doesn't carry a lot of weight as far as I'm concerned. I think what we do at simulation has to somehow relate to improving our care of the kids, and in some instances, for our OB colleagues, the pregnant patients carrying fetuses that will soon be kids. And this has to drive everything that we do. Just our learning objectives for the next half hour. At the end of this, I'd like you to know what types of clinically relevant issues lend themselves to study with simulation, and also be able to list some advantages of simulation-based research methodologies for looking at these clinically important questions. As a matter of disclosure, I am a paid consultant to Learn All Medical, and I won't be discussing any unapproved or investigated uses of commercial products or devices. In fact, I won't even mention any commercial products or devices. Now, if you think about it, you take a step back and look at, well, what kinds of research can be done? Really, when we think about the sort of the subjects of different types of research, there are subjects that are animals, organs, tissue, cells, molecules. Really, the focus here is on looking at biological processes in healthcare. Very common subject for research would be patients, and of course, there we're looking at clinical outcomes. Now, what sets us apart in many ways from a lot of the other more traditional forms of research is that we look at the healthcare professionals, the people who are actually delivering care to the patients. And of course, there we're looking at their overall performance. But also, we can think about studying various types of methodologies and studying various types of technologies, especially new technologies that are being introduced. And I think in those last three categories, that's where simulation is really especially useful. It has a number of advantages over more traditional ways of looking at things. You know, if we think about simulation, we don't have a need to obtain consent from a patient or from the patient's family. And especially in areas that I'm interested in, like resuscitation, it's very difficult to get consent under those kinds of circumstances. And so it's really helpful. Simulation is a very helpful tool when we're looking at questions that arise from dynamic, high-risk types of endeavors. The other nice thing about simulation is it really helps us to control many, if not most, of the variables that we encounter in real clinical practice. So when we think about doing simulation-based research, we need to think about setting these things up actually as a laboratory experiment. And the other thing that it allows for is that we can record the experiments with video, and we can analyze them later. So we don't have to do all of our analysis on the spot, nor do we have to be sure that we get everything right at that time, because we can always refer to the video record. Provides the opportunity to not just to answer a primary question, but other questions that may come up. And overall, things that are really difficult to study in the real environment are a lot easier to study using simulation. And that's what I'm going to focus on today. Now, I would like to make a bit of a bias statement about the types of research involving simulation. I've been thinking about this for a long time, having gotten started in this area way back in 1995. And, you know, the question of does simulation work? And I still see this question being posed a lot. And what I come back with is how much evidence do we really need to establish simulation-based learning as a standard in healthcare? Because it is the standard in a lot of other high-risk industries. And of course, if we look at the overall gold standard for research in healthcare, it's the prospective randomized placebo-controlled sufficiently powered multi-center trial. And even if, you know, I ask, first of all, do we need that to say that simulation is a standard? And secondly, if we need that, who in the world is going to fund it? Because it's very difficult to get funding for these kinds of projects. And when you start thinking about multi-center trials involving simulation, that's a very expensive undertaking. And so I'm not so sure that that's even realistic to think about. Of course, rational conjecture, it does make a lot of sense. We probably would like to move beyond that, though, and therefore get to something that's sort of in between. And if we think about what simulation actually is, in many ways, it's just practice. And you notice I use two different kinds of fonts there. I use a very fancy font for simulation. I use a very simple font for practice. And I think sometimes we get carried away with ourselves and we make simulation more than it really is, and we complicate things when actually we should be simplifying. And so if we think about simulation being practice, what I can tell you is my fifth grade baseball coach told me that if I practice playing baseball in a realistic situation, I practice doing the right thing, I'm probably going to be able to do it when I'm out there in a game. And so he was a blue collar guy, and he really, he knew that way back then. And so I don't want us to get too carried away with what we think simulation is and how we should use it and what we need to do to validate it. The reality is, for doing these kinds of studies, the window of time may have already passed us. If we look at the Joint Commission way back in 2004 and their Sentinel Event Alert number 30, they looked at root cause analyses of, at the time, I think it was 47, that's up to 109 now. Sentinel events involving newborns, 93 neonatal deaths, 16 survivors with severe neurologic morbidity. And their recommendations in looking at those root cause analyses was to, number one, you should do team training if you work in a place that delivers babies. You should run clinical drills and perform debriefings. Now, that was in 2004. That's 8 years ago. A little more recently, Sentinel Event Alert 44, which was published online in 2010, they looked at 84 maternal deaths. And they said that there's a result of that institutions where moms deliver should develop protocols for responding to any change or worsening in maternal condition, and they should use drills to train staff in those protocols. Also in 2010, in pediatrics, you see the article cited there, the consensus on science from the International Liaison Committee on Resuscitation said that, and this is an international consensus, said that simulation should be used as a methodology in resuscitation education, and it's reasonable to recommend briefings and debriefings during learning activities. And they said a very important thing, not just while caring for simulated patients, but also while caring for real patients during real clinical events. So the briefings and debriefings that we practice all the time within simulation can also be very, very helpful in the real environment. And when we look at a subsequent article that was published in the same issue, looking at the published guidelines for newborn resuscitation, for the very first time there were guidelines published around how do we learn newborn resuscitation. And those guidelines said that, well, based on the evidence that we see right now, it's recommended that the AAP, American Heart Association neonatal resuscitation program, adopt simulation briefing and debriefing techniques. So the evidence is already out there, at least as far as those groups are concerned. So I think that perhaps the window for looking at does simulation work, that's probably long past, and I think most folks now understand that it does. I think what we can do is we can look at different aspects of simulation, again, things that relate to what we do clinically, that can help us, either aspects of simulation that actually enhance how we can deliver the training and enhance the learning opportunities, or things that actually allow the healthcare professionals to improve their performance. And so as I thought about how to put this talk together, I began to think back to all the fellows that we've had at CAPE, our training center, over the years, and looked at the research that they've done. And the fellows have actually done a wonderful job of employing the scientific method and a fair amount of rigor in looking at questions that they felt were very, very important to this field. So I'm going to take you through a few of these. This first project was done by David Kagi. He was actually the very first CAPE fellow way back in the late 90s. And, we knew that at that time that people felt that, we had a lot of subjective feedback saying that, yeah, people say that this is real. They're telling us with their words that it's real, but what we wondered is, are their bodies actually responding as they would in a realistic resuscitation or realistic situation? So the question that David asked was, do trainees have realistic physiologic responses to simulation? And what we use as our methods is we put Holter monitors on a group of pediatric residents, and we put them into simulated and real newborn resuscitations. And we looked at an outcome variable called heart rate variability. And what the heart rate variability is, it's a measure of the relationship of sympathetic to parasympathetic output, which essentially is used as a marker for mental workload during a particular procedure or an activity. And so when David set this experiment up as his controls, each subject served as his or her own control. And the simulated resuscitation situations that we put them into were also standardized. So each scenario was the same from trainee to trainee. What the variables were actually the location. Did this happen in the simulator during a scenario, or were they in the real delivery room? And what we found was this was actually quite interesting. Our control situation for this actually was a standard NRP program, training program. And we used it, we looked at heart rate variability during the lecture component of that as well as the skill station component of that. And so when we compared the heart rate variability, or the low frequency to high frequency ratio in the simulator to what it was during those control activities during a skill station or lecture-based activity, we found that there was a statistically significant difference in elevation and sympathetic output. So people were more engaged during the scenario. Now, we also looked at their activities in the real delivery room. We had them keep activity logs, so we knew when they were resuscitating real babies. Had them looked at their heart rate variability there in the real delivery room, and compare that to that control situation in the standard training program. Found another statistically significant difference in heart rate variability. And then finally, we looked at the heart rate variability in the simulator and the heart rate variability in the real del room and found no difference. So what David found at that point in time was that simulation-based training, and actually at that time we were using very, very simple tools, can create mental workload similar to that encountered in the real environment, and therefore induce realistic behavior in the trainees. And that, after all, is what simulation is about. You want to make it real so that trainees will respond as they would in the real environment, and they therefore can discover their weaknesses and their strengths and find ways to address those weaknesses. Allison Murphy was our next CAPE fellow, and she actually got involved on the technology side. Remember, we said that evaluation of technology and methodology. David kind of looked at methodology. Allison was looking at technology. Those are both good uses for simulation-based research methodologies. And so at the time, we were developing an electronic fetal heart rate monitor. And so one of the early questions we asked is, does this device have content and construct validity? So the way Allison structured this experiment was she involved medical students and obstetric residents, and they were to interpret the fetal condition that was indicated by these simulated fetal heart rate strips that were being generated by the device. So the cases were the same from subject to subject, the cases that were presented, or the strips that were presented from the electronic fetal monitor simulator. And what was variable, of course, was the level of training of the subject. Were they a student or were they a resident? So when she began to look at this, the first thing she did, and under scenarios 1 through 4, is we actually looked at the responses, the interpretation, and then the response of the subject to what was coming out of the fetal monitor simulator. And we scored their response, was it appropriate or was it inappropriate, to the event that was being depicted by the fetal monitor simulator. And what you see is that for, at least in this instance, 2 out of the 4 scenarios showed a statistically significant difference, with the residents scoring at a much higher level than the students score. Now, another aspect of the work that she did was to simply look at 10 simulator-generated fetal heart rate tracings and provide some clinical background to those, and then have the subjects score these based on their interpretation of the baseline heart rate, any variability that was present or not, and decelerations and accelerations. So looking at the sorts of objective markers on the fetal strip that OBs look at. And what she found there is when she totaled those up for all the subjects combined is that there was a statistically significant difference. The residents did score higher than the students scored. So you look at this and you say, well, in conclusion, we saw that the residents achieved statistically significant higher mean scores than did the medical students in their accuracy in interpreting the fetal heart rate tracings. And we also did a little subjective survey at the end. About 80% of the residents said the tracings were realistic or very realistic. And so the conclusions to that study were that the fetal heart rate simulator that was developed exhibited both content and construct validity. And now those are common things that you do when you're evaluating any kind of new technology. Moving on to a later study that was done by Jody Anderson, looking at actual human performance. So we looked at how can we use simulation to study methodology, how can we use simulation to study a developing technology, and how can we use it to look at performance. So Jody was wondering about, can we use simulation to improve performance and experienced healthcare professionals in the ECMO domain? So what she did is she pulled subjects from our center, our Packard Children's Hospital. They all served as their own controls. These were experienced ECMO specialists. These are the nurses who sit at the bedside. And we created 2 standardized simulated ECMO emergencies. And we randomized each subject to receive one ECMO emergency first or the other ECMO emergency first. So they were randomized as far as order of scenario that was presented. And what she looked at is she looked at the responses, the skill, the things that we were expecting these people to do in the first ECMO emergency. And in the first ECMO emergency, and again, these are people who are practicing in the hospital every day. They're doing ECMO on a daily basis. And so one of the things we looked at is when there is a problem, either with the circuit, do they use the correct sequence in coming off of ECMO? And in the first emergency, we found that about 2/3 of the time that they did. When they were exposed to the second emergency, 100% of the time they did. So there was an improvement from ECMO emergency 1 to ECMO emergency 2. Likewise, were they able to troubleshoot the problem correctly? Only about 1/3 of the time in the first emergency do they do that. In the second emergency, it was 100% of the time. And we also thought pulling the O2 off the circuit so you don't end up with supersaturation of the oxygenated blood. Again, we saw an improvement from ECMO emergency 1 to ECMO emergency 2. We thought it was actually also very helpful to look at the amount of time it takes to come off of ECMO when there isn't a circuit emergency and actually begin to resuscitate the patient off of ECMO. And so the time to actually come off of ECMO, if we looked at the first emergency, it took the teams almost a minute. And in some instances, quite a bit longer than that to actually decide to come off of ECMO and begin to resuscitate the patient, whereas that time was reduced to about 13.5 seconds in the second emergency. And finally, the time to actually have someone start to deliver bag valve mask ventilation once you come off of ECMO, because of course, once you're off of ECMO, patient's got no means of respiratory support. And so someone has to start up bag valve mask ventilation to begin to resuscitate the patient. Again, it took roughly a minute plus or minus with emergency number 1. By emergency number 2, that time was reduced to 25 seconds. What was really interesting, that was technical performance, but what was really interesting to us is when we looked at behavioral skills that were associated with coming off of ECMO during an emergency. And what we found here is that of the 9 subjects that were enrolled, 8 of the 9 showed a statistically significant improvement in displaying these behavioral skills, and they're the 10 behavioral skills that have been embedded in the NRP, so they can be found in that literature. But 8 of the 9 actually showed statistically significant improvements from emergency 1 to emergency 2. One person in this instance, subject number 1, the reason why we think this person did not show any statistical significance in scoring and behavioral skills is that he performed at such a high level in emergency 1, getting 48.5 out of 50 possible points on the scoring tool, and he scored a perfect 50 on the second after the second or during the second emergency. He really didn't have much room to improve, but everyone else improved significantly, and overall certainly there was statistically significant improvement. And so we looked at both technical and behavioral skills, and in conclusion, we saw that participation, only a single simulated ECMO emergency resulted in statistically significant improvement in behavioral performance, statistically insignificant, but we felt clinically relevant improvement in technical performance. And this is, again, sort of one of the things we have to watch out for when we look at this kind of work using simulation. You may not see statistical significance, but you have to ask yourself, is it clinically relevant? Are you seeing what you think might be important clinical improvement? And certainly we thought in the time to come off of ECMO and the time to start bag valve mask ventilation, that being reduced to roughly 13.5 and about 25.5 seconds respectively from roughly a minute, we thought that was important and would make a difference to the patient. We also, I think, have to be careful of the flip side of this, having something that's statistically significant but clinically irrelevant. And we definitely don't want to go there. I think all of the work that we do needs to have clinical relevance. Anand Rajani, one of our more recent fellows, actually looked at a very important topic for neonatologists, comparing intraosseous access to emergent umbilical venous access. And what he looked at were variables of time required to do the procedure, error rate during the procedure, and perceived ease of placement. And again, he had each subject serve as their own control, and we also control the aspects of the simulated neonatal resuscitation scenario that they were put into. And the variable was whether the subject was randomized to either to use the interosseous needle or the umbilical venous catheter first. What he saw in looking at this is that in general, the average IO time, although not statistically significant in each group, each subgroup, was less than the average UVC time. And overall, if we look at all subjects, the time was statistically significant difference. There was a statistically significant difference. Average UVC time being about 105 seconds for the group of all 40 people. These are all healthcare professionals. And the average IO time being almost a little less than, or a little more than half of that at 59 seconds. He showed no significant difference in the number of errors that were made with either procedure or the perceived ease of use across all groups. Of course, that was a little surprising to us. We assumed that folks would actually perceive the IO to be easier, even because they were doing it faster. But what's interesting is these folks who are primarily neonatology-oriented type folks, the IO was not something they do very often, so their perceived ease of use was actually no different than the UVC. And so in conclusion to that trial, we thought that IO insertion we said IO insertion can be performed more quickly than UVC insertion. That was pretty clear. And that you should consider it when rapid intravenous access is required in the neonate, especially by those folks who do not routinely place UVCs, because we felt that those folks who don't routinely place those would probably take even longer than this highly specialized group, all of whom have familiarity with the delivery room. So just to wrap up here, since we're coming up on a half an hour, some other examples of some things that we're currently doing or about to undertake at CAPE. We've actually just completed a trial looking at a dedicated neonatal code cart versus the generic code cart that we use in our hospital. And we looked at things such as errors in the supply selection, as well as the timing to get appropriate supplies for certain types of deliveries. And that article, that manuscript was actually prepared by Ritu Shikara, our most recent CAPE fellow, and has been submitted for consideration for publication. Ritu also undertook a study, and I should say Anand Rajani played a role with that study, also a lead role with the code cart study. Ritu focused on looking at the accuracy of human senses in determining heart rate in a standard model during simulated neonatal resuscitation. She did a very interesting study where she compared the human ability, and this is all in experienced healthcare professionals, to pick up heart rate in a mannequin where the volume of the heart tones were standardized, the pitch, obviously, the tone was standardized, the location was standardized, essentially the background noise in the room was standardized, everything was standardized in this scenario. And she looked at not only could people accurately detect a heart rate, we compared what they told us they heard to what we had set the mannequin at, but we also looked at did their either accuracy or inaccuracy in heart rate determination actually influence what they did for the patient and their adherence to the NRP algorithm. And what we found was that not only are we as human beings unable to accurately detect heart rate, and this was fascinating given that we told folks in the consent form to participate in the study, that was the focus of the study. So they knew that we were highly focused on their ability to actually accurately detect heart rate in this mannequin. But we looked at errors of omission and commission. We found that people made significant errors of omission and commission that could potentially result in patient harm. And that article has also been submitted for consideration for publication. We are about ready to write a protocol to look at the ability of standard resuscitation teams, a standard two-person resuscitation team, to follow the NRP algorithm during standardized simulated neonatal resuscitation. Again, we want to look at error rate. We want to look at timeline adherence. We put a lot of things into the NRP algorithm that are timed And while the interventions themselves are evidence-based, the timing of those interventions, the amount of time we give people, is not so evidence-based. And so the question that we want to ask is, can the standard two-person team actually do the things they need to do in the time increments that are prescribed in the algorithm? We also want to look at using some tapes of several hundred tapes that we have of actual resuscitations. We want to look at communication patterns during healthcare professionals doing simulated and actual neonatal resuscitation and compare how we communicate to other domains like air traffic control. We think we can actually, in looking at that, develop a lexicon for more effective communication during resuscitation. A few other things just to make note of. We're going to use simulation to look at the accuracy and efficiency of data acquisition and communication or transfer at the bedside during rounds. We want to look at using what our current protocol or current model is in our NICU and compare that to a model that we think is better. And again, we're going to look at not only how fast can people acquire the appropriate data, but can they communicate it more effectively when they have a different type of technology available at the bedside. And then finally, a trial that we're beginning to develop the protocol for is looking at debriefing strategies that work in the real world. So looking at objective markers of debriefing quality that people can use on the fly. Again, busy professionals don't have a lot of time to attend a 3 or 4 or 5 or 6 day training program in debriefing, but folks who do this as part of their job, where you maybe have 5 or 10 minutes for a scenario and then maybe 10 or 15 minutes for a debriefing afterward, whether it's a simulated situation or it's a real event that occurs. So those are all things that we are working on currently. And with that, I think we have about 25 minutes left in the hour. So hopefully we have a few questions there that Mark can summarize and tee up for us, and we can take a stab at giving some answers.